Welcome to this lecture, which is an overview of auditory disorders. We're going to take a look at disorders in a very general sense first, and how they are classified by professionals in communication sciences and disorders. In subsequent lectures, we'll take a look in more detail at specific disorders and their impact on speech-language development and production, and how they are treated, diagnosed, managed by all the professionals involved, being physicians, audiologists, speech-language pathologists. So this is a broad overview of auditory disorders and their classifications. The references to this lecture can be found on BlazeView in the Hearing Disorders and Audiogram Interpretation document and Auditory Disorders Overview. It is essential that you read through both of these documents. Now, we're not going to cover all of the material in those documents. We're only going to cover the first few pages in either of those two documents, but please review them. The objectives for this lecture are fairly straightforward. The objectives are to present a classification system of disorders and to re-emphasize the impact of hearing loss on speech and language. Hopefully this produces somewhat of an organized framework for you to understand these concepts. Additionally, we're going to discuss how the SLP refers clients who may have failed a hearing screening protocol and who appear to be experiencing some form of hearing loss. Being aware of how and when to refer clients is crucial. And sometimes it's more crucial than the diagnosis or recognition of the problem yourself. Knowing when to refer is very important. Knowing where to refer is very important. Some of the terminology that we're looking at in this course. A lot of these terms, some of them are common. You've heard these before, but it's important. It's time now to make sure you know what all of these terms are. Some, but not all of these terms are used in this lecture, but it's up to you to be able to identify these terms, to briefly explain these terms and know what they mean. It's advisable for you to make note of these terms, and the way that I used to study for terminology like this was to make index cards, one card for each term, and of course on the back of the card was a brief description of the term. That's just my suggestion. It worked for me. It's not easy keeping track of all this terminology. So let's start by talking about what is a disorder. So we're talking about auditory disorders. We have to be able to define. We know auditory means related to hearing, and disorder, well, in general terms, a disorder is a disruption of systematic functioning. That doesn't even sound like something medical, but it is. A disruption of systematic functioning of the auditory system, or an abnormal physical or mental condition. These are very straightforward definitions of a disorder. Now, it gets a little more complicated. We have to differentiate between disorder, disability, impairment, and handicap. Now, unfortunately, all too often these terms are used interchangeably, and they should not. They all have very specific meanings. Now, we just talked about what a disorder is. Let's talk about a disability. A disability is an inability or a reduced capacity to perform a task in a specific way. It's an inability or reduced capacity to perform a task in a specific way. Whereas an impairment is the abnormality itself, any loss or abnormality of physical or psychological function or structure. And handicap means the impact or consequences of a disability, not the condition itself. In other words, the result of the disability's severity is referred to as the handicap. So the impairment is the abnormality itself. A disability is the restriction that is caused by that abnormality. And a handicap is the manner in which the impairment restricts the normal functioning of an individual. And it's important to note here, someone who has a disability doesn't necessarily mean they have a handicap. Okay, I'll repeat that. Someone who has a disability doesn't necessarily mean they're handicapped. The handicap refers to the distinct disadvantage the person experiences. It's important to think about that and think about examples of each of these. That question is going to crop up a little later on. Okay, hearing loss itself as a disorder. At this point, we need to emphasize that hearing loss is a medical condition, pure and simple. A medical condition. Something went wrong. Something went wrong in the middle ear or inner ear. That's the condition. And it resulted in a reduced ability to hear. It's a medical condition of the components of the auditory system resulting in a malfunction that inhibits hearing in some form or degree. The factors causing or contributing to hearing loss can be heredity, disease, infection or trauma. Let's consider for a minute other types of medical conditions and their impact. And the most classic and perhaps easiest to understand is vision. If there are changes, physical changes, or damage to the eye, it's going to result in some limitation of vision. Trauma is very obvious. Disease means something has happened, perhaps to the retina, and it results in a loss of vision. Likewise, something that happens to the auditory system, disease, trauma, any of that is going to result in some degree or difficulty hearing. A medical condition. As a medical condition, as with any medical condition, once it's identified, it has to be treated or managed. And as we will see, some hearing loss can be treated medically by physicians, particularly those physicians that specialize in the diseases of the ear, nose, and throat. They're known as otolaryngologists or otologists or otorhinolaryngologists. There's three different classifications of ear physicians. While some hearing disorders can be treated with medicine or surgery, there are some issues that cannot be treated with medicine or surgery. These types of hearing losses that cannot be treated with medicine or surgery are treated by audiologists and speech-language pathologists. Typically, the audiologist treats hearing loss through amplification, and the speech-language pathologist provides oral rehabilitation, oral meaning A-U-R-A-L. So, physicians can treat some forms of hearing loss if it's something that can be repaired or treated with medicine or surgery. If it cannot be treated with medicine or surgery, then it becomes the role of the audiologist to provide amplification and the speech pathologist to provide oral rehabilitation. Okay, we're going to shift gears here for a few minutes and talk about early intervention. This is a very popular area these days. This is an area where a lot of speech-language pathologists like to specialize, likewise with audiologists. We have today, according to the American Academy of Pediatrics, a program known as the Early Detection Hearing Intervention Program, EDHI. I'll repeat that. That's the Early Detection Hearing Intervention Program, developed by the American Academy of Pediatrics. And it was developed to identify infants at risk for hearing loss that interferes with speech and language development. The program outlines a protocol known as this 136 program, and I'll explain the 136 program. The 1 in 136 means that hearing screening should occur before 1 month of age. Ideally, screening is done the day of birth, but according to this protocol, all screening should be conducted at least before 1 month of age. And if there's any failure of screenings, a full diagnosis of those failed screenings should occur before 3 months of age. And if that diagnosis confirms hearing loss before 3 months of age, the child should be enrolled in an intervention program by 6 months of age. Now, that program can be as simple as identifying the child, getting them registered in an intervention program, and then perhaps the treatments such as hearing aids or cochlear implants may not occur until about age 12 months. But at least we have this structured, organized program. Full diagnosis of hearing loss is conducted by auditory brainstem response, ABR. And of course, if they fail the ABR, then they are hopefully enrolled in an intervention program by 6 months of age. This allows for adequate development of speech and language if they are amplified before they are a year old. Previously, without any kind of an organized program, children often went from 3 to 5 years before being accurately diagnosed with hearing loss and getting help. And that resulted in significant speech-language delays, in addition to other types of delays, social delays, economic delays. Today, at the preschool or K-12 level, efforts are made to conduct hearing screenings again, often by the SLP, to catch anyone that was missed in the early intervention program, the 136 program. And as mentioned, the SLP, speech-language pathologist, plays a crucial role in the identification and management of hearing loss through early intervention programs and in the K-12 screenings. Also, in skilled nursing environments such as nursing homes, the SLP, while not so much identifying hearing loss, because many of these older people would probably fail a hearing screening, but when they come into a nursing home, often there isn't a lot of information on them, and so the SLP might screen their hearing. And if they fail the screening, they should then be referred to an audiologist. And this is what I said very early in this program, that SLPs have to know when to refer people to an audiologist for hearing diagnosis. And so that happens in skilled nursing environments in nursing homes. I want to talk for a minute about the concept of the concept of differential diagnosis. Differential diagnosis is the process of differentiating between two or more conditions that share similar signs or symptoms. This is a structured approach to diagnosis, and it's critical to selecting the right approach to therapy. In order to provide therapy, you have to have an accurate, specific diagnosis. Without a diagnosis, how do you know what to treat in the form of therapy? So differential diagnosis means conducting a number of tests to make sure that one or more conditions that share similar signs can be identified so that we can clearly determine, for example, is this a conductive hearing loss or is this a sensorineural hearing loss? We have to differentiate, and we have different tests that help us to differentiate. So, bone conduction testing versus air conduction testing helps us with this differential diagnosis. Tympanometry, combined with audiometry helps us with differential diagnosis. Otoacoustic emissions and ABR are two different types of tests that help us differentiate conductive hearing loss from sensorineural hearing loss. Those are examples of how we conduct a differential diagnosis. Another very basic example would be on a more generalized concept, using blood tests combined with x-rays to help differentiate different types of medical disorders. We're going to talk about classification systems for diagnosing hearing loss. And there's a number of these systems: location, degree. We'll talk about these one at a time. Starting with location. This is a structured classification system, and it's important to keep in mind that this is a cursory overview of disorders, not a discussion of specific disorders. So we're looking at an overview. A more detailed discussion of specific disorders will come at a future date. There is a series of congenital and acquired problems that can occur with the external and outer ear. We know the difference between congenital and acquired. Congenital is at birth, acquired occurs after birth. So any of these problems can pop up with the outer ear, the middle ear, the inner ear, or the central auditory nervous system. Remember, the central auditory nervous system begins with the eighth nerve and then leads up through the brainstem and then across complicated pathways up to the auditory cortex. So, problems can occur by location in the outer ear, middle ear, inner ear, and we have differential diagnostic test procedures that can tell us where the problem is occurring in any of these locations. We classify hearing loss by the time of the occurrence. Again, congenital or acquired. Was it at birth or before birth? Congenital. There are a lot of syndromes that are congenital, occurring before birth. Now, many of these syndromes involve multiple systems, not just the auditory system, but hearing is often impacted in many of these syndromes. We're not going to cover all the syndromes in this course. It's too many. But syndromes are an example of something that occurs before birth. An acquired hearing loss, something that occurs after birth. And examples of acquired hearing loss are noise exposure, trauma, damage to the auditory system, ototoxicity, which is damage to the inner ear because of drugs or certain substances. What's most important to understand is the different types of hearing losses, either congenital or acquired, must be known to the audiologist or the SLP, again, in order to map out intelligent therapy. When the hearing loss occurred plays a very important role in its severity and degree, and that helps the SLP and the audiologist prepare their therapy or management approach. Likewise, classifying the disorder by type of disorder, auditory disorder. We've discussed some of these previously. We're going to go over them again. The most important distinctions to make here are that with conductive hearing losses are usually treatable by surgery or medication. There is an exception. There are chronic conductive losses that do not respond to medicine or surgery, but they are not common. So it is safe to say, generally speaking, conductive hearing losses can usually be treated by surgery or medication, whereas sensorineural hearing losses are permanent in most cases. There are a few rare situations where sensorineural hearing loss is reversed or reduced, but that is very rare. So it is safe to say, generally speaking, sensory neural hearing loss is permanent. So we're classifying hearing losses by type, conductive being perhaps temporary, and sensory neural being permanent. Mixed hearing losses are a combination of a conductive hearing loss and a sensory neural hearing loss, and perhaps the conductive portion can be treated and the sensory neural portion cannot be treated, but it's managed perhaps with hearing aids. We're not going to spend too much time talking about a central type of hearing loss because sometimes that's not even hearing loss. Sometimes a problem with the central auditory nervous system results in a disruption of the transmission of the signal, and without going into too much detail, it causes an unclarity or lack of clarity of the signal. So that's why we're not going to spend too much time on it right now. We will talk about central auditory processing disorders briefly later on in the course, but mostly we're concerned with conductive, sensory neural, and mixed. And we classify hearing loss by degree, meaning is it mild, moderate, severe, severe to profound. The degrees of hearing loss vary between pediatric and adult and from one textbook to another. It is safe to say that there is a very generalized degree classification provided by ASHA that can be applied to pediatric and adult cases across the board. And we'll take a look at this chart in the next slide. And ASHA says that if someone has thresholds that range from -10 to 15 dB, then those thresholds indicate normal hearing. If the thresholds are 16 dB to 25 dB at any frequency, that's referred to as a slight hearing loss. And then we go further down the scale, 26 to 40 dB and mild hearing loss and so on. So this is a more universally accepted scale, but you will see other scales. Some scales will say anyone who has thresholds from 0 dB to 20 dB, that's normal hearing. 20 to 40 is a mild hearing loss. There's nothing wrong with those scales. It's just that too many organizations get involved in producing these different charts, so it's best for us to go with the one provided by ASHA, and that's the one we'll use throughout the course. We need to talk for a few minutes about case history, and this is very important. There are many physicians today who will claim that they can diagnose as much as 90% of any medical condition based on the case history alone. Now that's pretty profound. They're saying by taking a good case history, they know almost completely what the medical problem is. And I believe that to be true. If the right case history is conducted, if the right questions are asked, if the symptoms are explored, most of the time we know what the problem is, and then we resort to testing to confirm our suspicion. So a case history, and you're going to call this an intake or a case history, and it provides general background information, and it goes into more specific prenatal and birth history. What was the mother's health like during pregnancy? Were there any complications at pregnancy? A lack of oxygen at pregnancy can result in some minor hearing loss. Did mom have any issues in pregnancy? Health issues? Was there any drug addiction, nicotine, caffeine use? All of these, when these questions are asked, can point to some certain red flags that might suggest there could be some hearing loss. Was the child ever hospitalized? Did they suffer from ear infections? Did they take any medications? Developmental history is very important, and educational history. How does the child act in school if they're school age? Going back to developmental history, when did they start babbling or talking or cooing? All of this information begins to help us profile the child's general health as well as their auditory health. We're going to talk for a few minutes about the distinction between symptoms and disorders. Now, we've defined a disorder earlier in the presentation as a description by the patient of what they are feeling or observing, such as dizziness or pain. So the patient describes what they are feeling. That's a symptom. A disorder is a disruption of systematic functioning. This is what we defined earlier. Or an abnormal physical or mental condition. So the disorder is a well-defined dysfunctioning system, whereas a symptom is merely a description. We have to throw in here a discussion of the term etiology. Etiology is the professional term used to describe the underlying cause for the disorder. You may hear someone say, well, they have a profound sensorineural hearing loss, and someone says, well, what was the etiology? Well, the etiology of the profound sensorineural hearing loss might have been exposure to loud sound over 30 years. That was the etiology or the cause for the disorder. So, if we're distinguishing between symptoms and disorders, let's talk about some very common symptoms, beginning with tinnitus. I'm going to say this and repeat it a couple of times. Tinnitus is a symptom. It is not a disorder. It might appear like a disorder. It's ringing in the ears or sounds that we hear in the ears, and you say, oh my God, what's going on in there? What kind of a problem do I have? Tinnitus is the symptom of some kind of a problem. In most cases, tinnitus is fleeting. It doesn't occur very long. Many of us experience tinnitus. Doesn't mean that there's something going on, but it can mean. That's why we have this very detailed case history and then testing to get to the bottom of these issues. So tinnitus is somewhat of a phantom sound occurring in the auditory system. It's a sensation of sound. It can be associated with, related to, hearing loss, or in severe cases, tumors of the eighth nerve, or even vascular diseases, cardiovascular diseases. But just because you hear some ringing in the ears or buzzing in the ears, don't go running out thinking you have an eighth nerve tumor. Those are very rare instances where tinnitus is a symptom. Tinnitus is a widespread phenomenon. Most of us experience it at one time or another. Some of us experience it briefly. I can tell you when you will experience it, and then you will experience it after exposure to very loud sounds. For example, firing a rifle or pistol. That's a very loud impact sound that will make our ears ring. The belief is that we're stressing the auditory system, and it's responding with some kind of a ringing or buzzing in the ears. So any type of loud sound, a gunshot, a loud concert for an hour and a half, just using a leaf blower for a half hour is so loud, when we turn it off, our ears are ringing. That's our body's way of telling us we have overtaxed the auditory system. Vertigo or dizziness, they are also symptoms of something else. They're symptoms of perhaps we've been moving too fast forward, riding a roller coaster or some kind of carnival ride. We have been forcing the vestibular system to compensate, and it shows up with a little bit of lightheaded or dizziness. Otalgia, O-T-A-L-G-I-A, otalgia, is a medical word for ear pain. Pain in the area of the ear. Now, there are lots of things that can cause pain in the area of the ear. Some of them aren't even related to the ear. Some of the things that aren't related to the ear are problems with teeth or the temporomandibular joint, TMJ. Even a problem with tonsils could show up as pain in the area of the ear. There aren't too many conditions that cause ear pain, auditory conditions. Sometimes a buildup of fluid in the eardrum rupturing will cause ear pain, but that's very quick, very mild, and most otalgia although it occurs in the area of the ear, is usually related to something else. The concept of aural fullness, A-U-R-A-L, aural fullness, really means simply a stuffed up ear or clogged ear. And that can be due to anything from changes in altitude, when you notice this when you fly, either ascending or descending. The eustachian tube is not opening or closing properly, so negative pressure builds up and you feel what we call a stuffy feeling called aural fullness. It's a symptom of something else going on. It's not a disorder. Usually when the plane lands and the pressure equalizes, the aural fullness goes away. Hyperacusis is a very interesting disorder. Symptom. Hyperacusis is a very interesting symptom, not a disorder. Hyperacusis is an abnormal sensitivity to ordinary sounds. For example, environmental sounds. There are people who, for some reason, feel like when the wind is blowing, it's just a painfully loud sound to them. And we're not sure what causes this. This is one of those vague areas, a strange one, in that, I'll give you an example. Kids learn very quickly. If they see you wince to a loud sound, they can say, hey, you got some attention from holding your ears. So they can often complain that everyday sounds are too loud for them, a form of hyperacusis. We don't see this often. It's a rather unusual symptom that we don't see much of. So factors that contribute to the accurate diagnosis, we've covered most of these, but the age of onset, it's a time factor. Did the hearing loss occur early in life, later in life? Is there a family history of hearing loss? And usually we're referring to mother, father, sisters, brothers. Beyond that, it's not likely that hearing loss is going to be passed on heredity-wise. General health conditions. There are a lot of general health conditions that can contribute to hearing loss. One of them is diabetes. People with diabetes often, the condition is accompanied by hearing loss. Cardiovascular diseases are often accompanied by hearing loss. Prenatal issues, I think I've discussed these already. If mom had a prenatal issue such as overusing alcohol or nicotine or certain drugs, those are prenatal issues that could lead to hearing loss that is evident at birth and would be referred to as due to hereditary issues. So in summary, this is a relatively short lecture, but we have given an overview of disordered terminology. And we've talked about the difference between disorders and symptoms. And it's important to especially make note of those disorder terms that are confusing, such as handicap and impairment. You really must know the difference between them. And we've classified auditory disorders by where they occur, middle ear, outer ear, inner ear, and when did they occur, prenatal, postnatal. We have this structured classification system. And we also talked about the differential diagnostic process, that being the process whereby we use multiple tests to pinpoint what a specific problem is. We can have a problem of hearing loss, but we have to figure out, is it conductive or is it sensorineural? So we have differential diagnostic approaches to determining what the hearing loss issue is. Okay, next up we're going to start looking at specific auditory disorders, starting from the outer ear and working our way inward. And we will talk about how they're diagnosed and the impact that they have on speech and language. So, you have a request for a discussion question related to this lecture that's posted to BlazeView. And I want to thank you for your attention, and that concludes our discussion of auditory disorders, an overview.